Welcome everyone to another wonderful episode here at Jaws of Podiatry. I think this is a fantastic case for a lot of reasons. Unfortunately, I think a lot of people will be able to relate. I want to be very, very clear. Today we're going to be performing what we call the Bifecta procedure, not the trifecta. The Bifecta is a combination of what we call the Percutaneous Microtenonomy in conjunction with whether it's PRP, platelet-rich plasma therapy, or what we call either BMAC or adipose-derived stem cell therapy. Whether it's a tendon, the plantar fascia, whether it's the Achilles tendon, but nonetheless, we have a young patient who has been battling for 1 year in duration a chronic pain to one of the main tendons of the foot. The patient presented to our office with an MRI at hand. The diagnosis that the MRI revealed was a severe degeneration of the posterior tibial tendon. Again, it's a very, very important tendon that we use on a daily basis. The patient, the patient presented basically saying that, I cannot continue with my daily life activities. So after careful evaluation, I recommended that we do the Bifecta procedure. Procedure number one, percutaneous microtenonomy. We're essentially doing it's a very old technique. It's kind of like an acupuncture type of technique that we perform. The reason why we do that is to actually try to we trick the brain into believing that there's a new injury to the area. That when we talk about injuries, especially chronic injuries, this has been present for 1 year in duration, so it is considered a chronic injury. It's not acute, it's chronic. So what we basically need to do, whether it's the posterior tibial tendon, the Achilles tendon, or the plantar fascia, or any other injury, we want to try to convince the brain into believing that there is a new injury. And how do we accomplish that? We accomplish that by performing the first part of the procedure, the percutaneous microtenonomy. And again, we'll go ahead. The first part of the procedure, we use a tiny little needle. Okay. We've already marked the areas. This is actually the tibia, the navicular. The navicular here, this bone, is where the posterior tibial tendon comes around, wraps around, makes a U-turn, and it inserts here. It attaches here. So I've already demarcated the affected area. Okay, the tendon is definitely thickened and enlarged. There is a significant amount of inflammation as well. Luckily, there is no partial tear of the tendon itself. So the patient actually came in at the right time. So without further ado, again, the first part of the procedure is, nice and slow. You okay there, patient? Super. We basically just fenestrate the tendon. Okay. And again, Dr. Wagner, why are you doing this? We're doing this because we are tricking the brain into believing there's a new injury. But why would we want to do that? Because I want the brain to send this anti-inflammatory cascade, down to the affected area. Remember, the brain doesn't know the difference between a hammer, a book, or in this case, a little tiny needle, right? So that's the first part of the procedure. The second part of the procedure is the PRP. Okay, we've isolated about 3 cc's and change, and now we're going to go ahead and infiltrate all of this area with the PRP. The PRP, again, just to refresh everyone's memory, platelet-rich plasma. Platelets contain, well, wait a second, Dr. Wagner. Platelets play a role in coagulation, right? Which, stop the bleeding. So tell me a little bit more about the platelets, Dr. Wagner. Well, inside these platelets, you have important growth factors and important proteins and important cells that aid in the regeneration of damaged tissue. It helps with reducing or lowering inflammation. So again, whether it's this tendon or any other tendon, you know, we continue to use PRP as an alternative once we've exhausted everything else to continue our efforts to maximize improvement and minimize any long-term complications. So, you know, what I like to do is I always tell patients that there might be an element of discomfort. Yes, there is a local anesthesia that we've already infiltrated, but there may be some a little bit of discomfort. The PRP may actually move this way or this way. So we'll go ahead and start, you know, right here, okay, and slowly move in and stop there, okay. Now I'm going to tell the patient we're going to go ahead and start infiltrating the PRP. And very slowly. Again, I've said it before and I'll say it again, more is not always better. It doesn't work like that. You want to put in just the right amount. Okay. You see how it went over here? So we want to make sure we keep all the PRP over here. So what I'm going to do is I'm going to redirect actually this way a little bit. Okay, we got a thumbs up there, that's good. So slowly. You see it's bubbling, so I know I'm in the right place, right location. Just nice and slow. So then I'm going to stop there, okay? And then I'm going to put a little bit around this area here near the navicular bone. Okay, we're coming through here. Okay, right here. Put a little bit more here. Dr. Wagner, what's it, you know, what happens after you're done? Our recommendation to mobilize the area because of because the patient has been battling this for such a long time. ¿Está bien? Excelente. Because the patient has had this problem for so long, we're going to take a really aggressive and robust approach. Okay, we're all done. Okay. So what we're going to go ahead and do is, today is Thursday, Friday, Saturday, Sunday, Monday, the patient's going to come back. And instead of just applying, you know, having her use the cam walker, the ugly boot, right? Not the Gucci, not the Prada. We're going to totally immobilize the extremity. We're going to apply a below the knee cast for a minimum of 3 weeks. And then we're going to stop there. And then at that point, we'll reevaluate. I want to be very clear with the public. PRP is not a miracle injection. It is a physiological process. What do I mean by that? I mean, there's got to be a connection between brain and foot. And in some people, it happens quicker than others. Again, how do I define success in a situation like this? Is just like I told the patient, if we can get the clinical presentation 50, 60, 70, 80, 90% better, right? That's how I define success. I'm not in the business of telling people, hey, you're going to be feeling 100%. Right? It doesn't work like that. So our goal is maximize improvement, minimize any long-term complications, and eventually, right, even though we spoke about it very, very briefly, avoid the knife. Surgery. As always, www.jawspodiatry.com, Instagram, Dr. Toe Jam, Jaws Podiatry, Facebook, and last but not least, our YouTube channel, Jaws Healthcare. Have a wonderful day, everyone.